Good morning, everyone. Welcome to Grand Rounds. And we are going to have our introduction this morning by Mia Reckowitz.
Good morning, everyone. Thank you for joining. Our presentation today is supported by the CF Foundation. So we're really grateful for that support. Dr. Nicole Green was born in London and moved to the US for college, where she received her BA degree from Amherst College and an MD from Columbia University College of Physicians and Surgeons. Dr. Green completed pediatric residency at New York Presbyterian Hospital, Weill Cornell, before moving to Seattle for pediatric GI fellowship at the University of Washington. Dr. Green is currently an assistant professor of pediatrics at the University of Washington School of Medicine and an attending physician in the Division of Gastroenterology and Hepatology at Seattle Children's Hospital. Her academic mission is to improve the GI outcomes of patients with cystic fibrosis. She received a Digest Award from the CF Foundation, a 3-year grant designed to build clinical expertise in the GI care of CF patients. She has established a research and clinical focus in CF-associated GI and liver disease. During GI fellowship, she designed a prospective pilot study assessing the feasibility of a dietary intervention, exclusion of processed foods to influence GI symptoms, intestinal inflammation, and stool microbiome in pediatric patients with CF. She is a site PI for PUSH, an NIDDK-sponsored multi-institutional study aimed at determining the utility of abdominal ultrasound as well as other imaging modalities and biomarkers to predict the development of advanced liver disease in pediatric patients with CF. She was recently awarded her institution's Clinical Research Scholars Award to support further research in CF-related liver disease and the interaction with the GI microbiome. Dr. Green enjoys multi-institutional projects and is collaborating on CF-related projects both at a national and international level with the goal of continuing to lead advancements in the field of CF-GI and liver disease. In her free time, she enjoys running and races at the elite level in both marathons in the US and the UK. So I feel very lucky to be able to learn about this topic of CF-related liver disease from someone who is obviously so knowledgeable and passionate about it. So I'll turn it over to Dr. Green.
All right, thank you for that kind introduction. I will share my screen. We make sure that we have everything. This is always the interesting part. Hopefully everyone can see my slides, but again, yes, thank you for that introduction. Today, I would like to speak about cystic fibrosis liver disease. As we discuss some sort of awards or disclosures, I did previously receive the 3-year Digest Award to support clinical training in CF-GI disease. I'm part of the PUSH study, and I'll touch on that research a little later in this talk. And then I have an institutional grant to support further research in CF liver disease. So because we're not all here pulmonologists or necessarily take care of patients with cystic fibrosis, I would like to start today with an overview of cystic fibrosis. So I apologize if this is too basic for some people, but just get everyone on the same page, and then I will move on to discussion of liver disease. So as many of us know, cystic fibrosis results from mutations in the cystic fibrosis transmembrane conductance regulator protein. So that's CFTR from here on out. It is the most common life-threatening autosomal recessive disorder. So the way I like to think about it is that CFTR is expressed on the apical surface of epithelial cells, really anywhere there is a tube in the body. So obviously we all think of the lungs because CFTR is expressed in the bronchi, and this has been, the most prevalent manifestation of their disease. But it's also expressed in the biliary tract, the pancreatic ducts, the intestine, and the reproductive system. So really tube-lined areas in the body often have CFTR expression. When CFTR is mutated, you get disruption of epithelial iron and water transport. Really, you get a reduced bicarbonate secretion, and water tends to follow bicarbonate. So as a result of mutations, you get an acidic, thick, viscous secretions in these tube-lined organs or tubes, which results in sort of obstructive features and various manifestations that you see in cystic fibrosis. So basically, just think of thick, sticky secretions in various tubes of the body. As many of us may know, but there are various CFTR mutation classes, and they sort of fall into different degrees of severity based on what part of the protein or the protein formation is affected. So the most common CFTR mutation is the F508del, and that is a class 2 mutation. So in these cases, the class 1 or the class 2 mutations are thought of as more severe mutations because either no functional CFTR is created, or CFTR protein may be created, but it does not fold correctly and won't reach the cell surface. The class 4 and the class 5 mutations are typically thought of as less severe mutations because you still form CFTR protein, it will move to the cell surface, but the CFTR channel might not function appropriately or might not be present in sufficient quantities. So this slide is just to highlight what I wasn't aware of going into GI fellowship, of all the areas of the body that can be affected in cystic fibrosis. So obviously more than just the lungs. And from the GI perspective, there's, I'll focus on the liver today, but the pancreas is obviously highly affected in cystic fibrosis, with over 80% of patients being pancreatic insufficient, requiring exogenous pancreatic enzymes for their digestion. Growth is a really important thing to think about in the cystic fibrosis population. And then there are a ton of presentations in the GI system or intestines from CF, starting at birth, where you can get meconium ileus, which is a sort of small bowel obstruction, to constipation, rectal prolapse. And the other thing to know, outside of all the sort of symptoms that CF patients can have as a result of their GI disease, there's also increased intestinal inflammation in cystic fibrosis compared to the general population. And they are developing GI malignancies, specifically colon cancer is the most studied, but they are developing that at a much higher rate, earlier as well than the general population. So now recommendations are that adults with cystic fibrosis are screened earlier than the general population with screening colonoscopies. They are actually being screened now starting around age 40. So again, I didn't go into GI fellowship thinking about cystic fibrosis at all. That wasn't something I was, had even crossed my mind as a GI doctor. So for all the trainees out there, my just plug is to keep an open mind, because I would not have been involved in cystic fibrosis had it not been actually for my division chief at the time, who approached me literally in the hallway and was asked if I was interested in cystic fibrosis or going to work with a pulmonologist in CF clinic. And I was really confused because I was like, she knows I'm a GI fellow, right? But that was my ignorance, because the more I learned, the more I realized that cystic fibrosis encompasses all the aspects of GI that I was interested in. So inflammation, nutrition, motility disorders, they really, dysbiosis, they really have it all. So in this one disease phenotype, and actually from the CF community, itself, they have expressed a desire for more focus on their GI symptoms and disease, which really does affect their quality of life. And, you know, the good thing is that that CF patients are living so much longer than they were, you know, decades ago. But now GI complications are becoming an increasing cause of morbidity for them. So it's great that we have people interested and willing to focus or even ask them about their GI disease, which was previously not happening so much. So again, as we talked about, CFTR is expressed throughout the intestine. There's high expression in the beginning of the small bowel around the duodenum, and then expression decreases as you move through the small intestine. There's moderate expression in the colon. There's pretty significant expression in the pancreas, and then it is also expressed in the bile ducts and gallbladder. And then something to note, it is not expressed on hepatocytes, which will become a little more relevant as I move on to talk about the liver. And it's also expressed in sort of the nerves of the GI tract in the myenteric plexuses. So my objectives today are really to examine the spectrum of CF-associated liver involvement, to explore the pathogenesis of CF liver disease, which is not clearly understood, but to discuss the various theories. Really, my focus is wanting us to be thinking more about CF liver disease so that we detect it and can manage any complications better. This talk is actually pretty timely because the CF Foundation just released new liver disease guidelines that I actually was part of creating, and we've just released those for review, which may change practices for a lot of groups in terms of screening and monitoring. And then, you know, I would like to discuss the Cftr modulator medications and their potential influence on CF liver disease. So just a reminder, Cftr is expressed on the apical surface of intrahepatic and extrahepatic cholangiocytes. It is not expressed on hepatocytes themselves. Why do we care about liver disease? So as based on the 2020 CF annual report, CF liver disease was the fourth leading cause of death among the CF population. It was actually previously always the third leading cause of death, but sadly in 2020, it was taken over by suicide and a drug overdose, but obviously not as significant as respiratory or transplant complications, but still pretty significant in cause of morbidity and mortality. And I think as we have these new CFTR modulator medications, you know, respiratory health is definitely being shown to be improving so much, and liver disease might be rising in terms of pathology for these CF patients. So I'd like to start with, or just get everyone engaged with an audience response question. So what do you consider CF liver disease? So it would be elevation in liver enzymes, so AST, ALT, enlarged liver on physical exam, imaging abnormalities of the liver, so fatty liver fibrosis, or just textural changes, or liver cirrhosis and or portal hypertension. And you can select all that apply for that. Oops, sorry, I'll go back. And I don't know how to see when everyone's, or when enough people have looked. So you just tell me. Okay. So yeah, all over the board, which is great because that's exactly what I want to discuss in the next section. So the big thing to know is that it is not well defined what we mean by CF liver involvement. So I might get a referral saying CF liver disease, And that can mean one of 5 different things, which makes things confusing, and it also makes it difficult to determine prevalence of CF liver disease or look at risk factors. So, research in the field has been really, sometimes delayed by those kind of things, with everyone meaning a different thing by CF liver disease. So as you can see, elevated labs might be present in 20 to 30%, and this is persistent elevation in liver labs. But there's also, which I'll talk about individually, a variety of phenotypic presentations of liver disease and CF. And some of them have definitely more clinical significance than others. So in light of this, the CF Foundation is trying to standardize some terminology. And this is based on the most recent CF liver disease guidelines. And what they're trying to do is separate advanced CF liver disease, or ACFLD, from what we're now terming CF hepatobiliary involvement. So advanced liver disease would be one of the following. So a nodular liver, that's typically on imaging that you would see that. Advanced fibrosis or cirrhosis, so like advanced scarring of the liver. Multilobular sclerosis, which I'll talk about, with or without portal hypertension. And then there's an entity in CF that we have discovered which is called non-serotic portal hypertension, which I'll go on to discuss. CF hepatobiliary involvement would be any of the following without features of advanced disease. So enlarged liver fibrosis that is not so advanced or scarred as the advanced fibrosis, increased liver stiffness by elastography, and then various sort of other presentations of the liver. So fatty liver, focal biliary cirrhosis, cholestasis, sclerosing cholangitis, which is the sort of a variant we can see in cystic fibrosis, and hepatolithiasis. So I'm just going to go over some various clinical presentations. I'm going to start with multilobular sclerosis because this is the most clinically relevant in terms of what we worry about from liver disease and cystic fibrosis. So as you can see in the explant specimen on the right, this involves multiple diffuse regenerative nodules on the liver. And on exam, if you were to feel the liver, it would feel hard and bumpy, but it might not necessarily be enlarged. In fact, cirrhotic livers are often shrunken, so you may not feel a liver on physical exam, which is why it's important to also think about imaging. In that image B, you can see an ultrasound image of the liver where you see sort of multiple large nodules throughout the liver. Liver biopsy would show cirrhosis, but it might not pick it up or lack sensitivity because multilobular cirrhosis in cystic fibrosis can be pretty patchy. So when you go in for a liver biopsy with one tiny sort of needle gun, you might not capture the area of significant cirrhosis. Multilobular sclerosis has obviously a risk of progressing to portal hypertension with the various complications. But the thing I really want to highlight here is that unlike a lot of cirrhotic liver diseases, this is really a pediatric disorder. The median age of diagnosis is 10 years old, which is young compared to most liver diseases. So you have to have a high suspicion and be looking for it to detect it early or before it's become very advanced. Another clinical manifestation, which I want to talk about, is non-serotic portal hypertension or portal venopathy. So typically, when we think of portal hypertension, we think a person has a cirrhotic liver, which is creating more resistance to blood flow through the liver, and you get back pressure, which results in portal hypertension, which results in enlarged spleen, which then we get thrombocytopenia due to splenic sequestration, and GI varices form. However, in this phenotype in cystic fibrosis, you can see evidence of advanced portal hypertension without having cirrhosis of the liver. And so I'll talk about that a little later, but it is something to be aware of. And this typically presents slightly older, sort of adolescents and adults. I'll talk about this more later, but in terms of clinical manifestations and complications of cirrhosis and portal hypertension, the big ones we worry about are esophageal or gastric variceal bleeds. Synthetic liver failure can occur, but is rarer, about 10%. But there's also increased risks of malnutrition, which is something we obviously think about highly in the CF population, insulin resistance and CF-related diabetes, and increased rates of hepatocellular carcinoma. I'm not going to talk too much about focal biliary cirrhosis because it's typically clinically silent. Just be aware that it exists. If you were to do an ultrasound, you might see a focal area of micronodularity that's circled there. If you were to do a liver biopsy, which again is not indicated typically in this case, you might see focal portal fibrosis and inflammation of cholestasis and bile duct proliferation. But again, these are mostly found, it's pretty common when you look at postmortem examinations, but typically it has much less clinical significance compared to the multilobular cirrhosis. Fatty liver or hepatic steatosis was typically, associated with malnutrition in CF and deficiencies of essential fatty acids. However, sadly now we are seeing increasing rates of obesity in the CF population, which was previously unheard of. And that's, I think, largely thanks to these Cftr modulator medications. But yes, we're seeing a lot more overweight CF patients. And so just like the general population, their hepatic steatosis might be from not directly from CF, but more of a sort of metabolic syndrome and being overweight. Biliary abnormality. So you can see what looks like a primary sclerosing cholangitis phenotype, where you would have areas of narrowing and dilatation in the intrahepatic bile ducts. Again, this is typically an incidental finding. It does not require treatment, but there is a risk of developing hepatolithiasis. And then the earliest manifestation of CF liver involvement is cholestasis. And the thing to know is that they can look exactly like biliary atresia, but it's important to do a full workup in these cases. We actually had an infant, a newborn, at Seattle Children's who the pulmonologist literally just curbsided me about and said, hey, we have this newborn with, CF cholestasis. They'll probably follow up with you in a few months in clinic. And I was like, hold on, okay, let's just be sure. And I was like, can you just get an ultrasound before, they send them to me? And we got an ultrasound, and essentially, long story short, the baby had biliary atresia in addition to cystic fibrosis. So, which is a very time-sensitive diagnosis to make in terms of surgical intervention. So do not assume that all CF infants with cholestasis, it's all secondary to their CF. Definitely the main thing is make sure they don't have biliary atresia as well, which of course is highly unlikely, but worth not missing. But simple CF cholestasis typically resolves within 3 months. Okay, so I think it's important to understand sort of the different theories behind the pathogenesis of CF liver disease. And as I alluded to, there isn't one single theory, but the most popular, I think, is this intrahepatic biliary obstruction, which again, we go back to that thick, sticky mucus due to defective CFTR that's obstructing the intrahepatic bile ducts. As a result, you get an accumulation of toxic bile acids, depletion of hepatic antioxidants. Ultimately, this leads to liver cell injury, inflammation, and activation of stellate cells, which result in hepatic fibrosis and cirrhosis. However, we know that all patients with the same CFTR mutation don't necessarily develop the same liver disease phenotype. So it can't all be just this defective CFTR in the bile ducts. So perhaps there are non-CFTR genetic or environmental factors that are also at play. That brings me to another theory, which is something I'm looking at more in terms of my research, just because I'm interested in GI inflammation, the gut microbiome, but this is the gut-liver axis theory. So the idea here is that we know CF patients have increased levels of intestinal inflammation, and perhaps increased intestinal mucosal inflammation, which would then result in sort of ulcerations in the bowel or erosions and a more leaky gut. Plus you have this thick, sticky mucus, and altered motility through the small intestine, resulting in perhaps bacterial overgrowth of pathogenic microbiome. And so inflammation plus bacterial dysbiosis in the intestine, and you get sort of translocation of these more pathogenic bacterial factors into the portal circulation, resulting in liver inflammation and fibrogenesis. So this theory was explored a little more in a small pilot study where it was Flass et al. And what they did was they took 11 patients with CF and advanced liver disease or cirrhosis. So these were, I think their median age was about 12 years old. And they matched them to CF individuals without any liver disease. And part of the study was having these individuals swallow a capsule, a video capsule. So video capsule endoscopy is a large pill that records video as it moves through the small intestine. And you can see images on the bottom left. So the far left image is from a CF patient without any liver disease, and the one on the right is from one with cirrhosis. And what they found was that there were increased inflammatory lesions on capsule endoscopy. So we're talking erosions or ulcerations in the cirrhotic patients. And there was also slower small bowel transit in those patients with cirrhosis compared to the matched controls. They also looked at fecal microbiome and found that there was correlations between those who had these ulcerations and erosions and changes in the fecal microbiome. And then in general, there was a trend towards higher abundances of firmicutes and lower bacteroidetes in the CF cirrhotic patients. So, obviously microbiome studies are hard, what caused what, sort of chicken and egg, but this definitely sort of got people thinking a little bit that there may be a relationship between the intestinal tract and liver disease. Interesting, they also looked at this lactulose mannitol ratio, which is a urine test measuring small bowel permeability. It's a surrogate to look at small intestinal permeability, and typically ratios greater than 0.03 are associated with increased small intestinal permeability. So as you can see here, all CF patients in this group had increased small intestinal permeability. Why that is, there's different hypotheses. You think maybe with the dysfunctional CFTR, you don't get that buffering capacity from bicarbonate being released into the bowel. So maybe a more acidic environment and more damage to the intestine or erosions, resulting in increased permeability. And then the fecal calprotectin is just a measure of GI or intestinal inflammation. So those numbers are not super high, but definitely increased, or at least borderline when we think of GI inflammation. And then just to talk on the final sort of pathogenesis theory, and this is really looking at thinking about those patients who develop non-serotic portal hypertension. And again, this is that interesting entity where you don't have a scarred down, really cirrhotic liver creating increased pressure through the liver, but you're still seeing evidence of back pressure and portal hypertension. So this was looked at more by Witters and colleagues, and they recruited people with CF and portal hypertension and obtained liver biopsies. And basically what you're seeing, if you're not familiar with liver histology, was that they found an absence of portal veins in over 40% of portal tracts. So those are shown with the asterisks, and typically portal tracts all have a portal vein. So they discovered this portal branch venopathy in this group of patients. Why that happens, they came up, there's different theories that have been hypothesized. One idea is that cystic fibrosis is an inflammatory condition, and platelets tend to be higher or activated in disease or inflammatory diseases. So perhaps you have a thrombosis of a distal portal vein. The other thing to know is that there are increased markers of vasculitis in CF. So maybe this is a primary vasculitis. Perhaps recurrent pulmonary and intestinal infections result in a septic embolization of small portal veins. Maybe it's that gut inflammatory infiltrate dysbiosis, bacterial translocation theory creating inflammation. And then finally, CFTR is also expressed in vascular smooth muscle. So perhaps there's a direct effect of CFTR on the liver vasculature. We don't really know, but it's something people are looking at to understand better this entity of non-serotic portal hypertension. So again, there's more than just CFTR contributing to risk factors for advanced liver disease, but we do know that risk factors for CF liver disease include the more severe CFTR mutations, so the class 1, 2, and 3. This also goes along with those individuals having exocrine pancreatic insufficiency. The only other genetic modifier that has been sort of consistently identified is the heterozygous state for the Z allele for alpha-1 antitrypsin, and that's associated with a 7-fold increased risk for the development of advanced CF liver disease. So it's worth checking in your CF patients the alpha-1 antitrypsin phenotype if you're concerned for liver involvement. So I will say off the bat that currently there is no treatment for advanced CF liver disease. So really the focus and the big push for myself and from the CF Foundation is to be better at identifying individuals at risk for CF cirrhosis. And I'm glad I'm talking to a pediatric group because, again, this advanced liver disease develops early. So we have to be better at looking for it. And then really the monitoring and intervention revolves around sort of mitigating complications of advanced liver disease. Of course, not every patient with CF has CF liver disease, and they could have other types of liver disease. So it's important to rule out other things in this group. So infectious hepatitis, autoimmune hepatitis, celiac disease can also affect the liver. Alcoholic fatty liver is not something we see as much in kids, thank goodness, but non-alcoholic fatty liver disease is also a consideration. So I'm going to go through some screening and monitoring recommendations and just give you my thoughts on them, and also try and incorporate these new CF Foundation liver disease guidelines that have recently been released, just so that you're all up to speed. But in terms of labs and physical exam, the CF Foundation recommends annual screening for liver involvement with an examination of the liver and spleen, as well as measurement of AST, ALT, GGT, and bilirubin on an annual basis. So obviously everyone varies in terms of their comfort with examining the liver and spleen, especially if you're not a GI doctor. You may not be spending all your day feeling the liver and spleen, but that's the part of the recommendation. And then the other thing I really want to emphasize is obtaining those labs at a time of clinical stability. So your AST, anyone's AST, ALT, even GGT, may rise in the setting of infection or likely rises in the setting of infection, even if just a mild virus. So it's really difficult to interpret if you're getting these labs in the middle of a CF exacerbation or just, a bad cold, because then, we end up just repeating them. So the idea is to get them at a time of the patient's baseline health. However, AST and ALT are really produced products of the hepatocytes when they're under stress. So as you can imagine, as I said at the beginning, CFTR is not expressed in hepatocytes. So these labs lack sensitivity and specificity. So you could have elevated AST, ALT, and really have no CF liver disease, and vice versa. You may have CF liver disease and your labs be normal. So there's been a more recent push to use biomarkers of fibrosis, which weren't created for CF, were being used more in, like, say, hepatitis C, but we're trying to adapt for the CF population. And as you can see, there's equations there on the right, that these include APRI, Fib4, and GPR, if you hear those terms being thrown about. And there's various online calculator tools that you can use to calculate these. And we think they might be more useful than just the straight labs themselves in defining fibrosis. And the thing I want to emphasize with these is to use pediatric specific normative values, because most labs do not, the upper limit of normal is based on adults and not pediatrics. So you really increase the sensitivity of these lab screening tools if you're using pediatric normative values. And then the other thing which I always look at is a decrease in platelet count over time. So as I said, platelets might be higher in the CF population in general, just because of them having a more inflammatory condition. But if I'm seeing, so they may not necessarily be thrombocytopenic if they have liver disease. But what I like to look at is a trend over time of decreasing platelet counts, and just something to be aware of. All right, so guideline recommendations, just so that we're all aware. Persons with CF and advanced liver disease. So these are patients we've already identified with advanced liver disease, should actually have labs obtained more frequently. So at least every 6 months to look at progression of liver disease. And if you have the CF hepatobiliary involvement, they also recommend one of those liver fibrosis scores being calculated at least annually. Second audience response question: when and how often should liver imaging be obtained in persons with CF? So is it in the setting of persistent liver lab abnormalities, if there's enlarged liver or spleen, on exam, every 2 years starting from diagnosis of CF, annually after diagnosis of CF, hepatobiliary involvement, or advanced CF liver disease, or at the discretion of your gastroenterologist or hepatologist? Okay, so again, lots of different answers, and I'm going to say that as of, a few weeks ago when these liver disease guidelines were released, there wasn't a consistent answer, and none of those would have been wrong. But in terms of new guidelines, this is probably going to change practice for a lot of people, well, a lot of people who care for CF patients, because now we're recommending an ultrasound at least every 2 years in all persons. And this is everyone with CF within 1 to 2 years of diagnosis. So that's a significant ask, obviously, for this patient population who are already busy and, have a lot of various medical needs. But the thought was that, this will increase detection of liver disease, and that might otherwise be missed if we're just relying on labs and physical exam. There definitely seems to be an association with liver ultrasound changes and lab abnormalities. And then ultrasound can detect that multilobular nodularity or even findings suggestive of portal hypertension. You can see an enlarged spleen, for example, but it might not be so sensitive at detecting earlier stages of liver fibrosis. You might see non-specific changes in the liver, which can be seen with both fatty liver and fibrosis. And we've shown in a couple of studies that there is a lot of intra and inter-observer variability. So at my center, I like to, if I'm worried about an ultrasound finding, there is one, radiologist who is very familiar and has had specific training in interpreting CF liver imaging. So, that's something to think about. And, a normal ultrasound usually will, but not always exclude severe CF liver disease. I will quickly talk about the PUSH study, which I was involved in. And this was looking at the utility of a research-based ultrasound. We're looking at other imaging modalities as well, but the main idea was a research-based ultrasound, meaning these radiologists were highly trained to look at liver ultrasounds in CF patients, and they were trained as part of this study. And we were trying to see if there were ultrasound findings that would predict which individuals were going to go on and develop advanced liver disease. And what we found was that those with a heterogeneous liver ultrasound pattern at baseline had a 9-fold increased incidence of developing a nodular pattern, which is a surrogate for advanced liver disease, within 4 years. So it was 23% in the heterogeneous group that developed nodularity versus 2.6% in those with a normal liver appearance on baseline. So obviously that is, something we need to think about if we see a heterogeneous liver on ultrasound in these patients. But also another thing to remember is that over 75% with the heterogeneous pattern did not develop nodularity. So, definitely a clue there, but, nothing we can say for sure. I'm not going to touch too much on MRI or MRCP. Basically, there really is insufficient evidence to recommend routine use of MRI in CF patients, but you might detect that, you'll look at the bile ducts more closely and you may detect sort of a periportal fibrosis or a sclerosing cholangitis variant. Newer modalities that we have at our disposal, I'm sorry, these graphs are small, but I'll go over them quickly. So FibroScan or Transient Elastography is a pretty easy test to do, and you can do it in clinic. And it uses low frequency acoustic wave propagation to measure liver stiffness. And it has been shown that in adults, increased transient elastography, so greater than 6.8, is associated with markers of CF liver disease in terms of your biomarkers of fibrosis and your AST and your platelets. So it may be more helpful to distinguish mild versus advanced fibrosis. Shear wave elastography uses ultrasound to measure liver stiffness, and again, it correlates well with labs and markers of portal hypertension. So that's something you can add to an ultrasound at the time to get a better sense of fibrosis. So again, new guidelines. CF Foundation recommends persons with CF who have hepatobiliary involvement should undergo a baseline liver elastography for the identification of advanced liver disease. So that's the FibroScan or the shear wave elastography, and that if people do have CF hepatobiliary involvement or advanced liver disease, we should repeat these tests at least annually to measure progression of disease. So not only can it detect fibrosis or CF hepatobiliary involvement, but it can be more sensitive and used to follow progression of liver stiffness over time. Liver biopsy is typically thought of the gold standard for detection and staging of liver disease. but we don't routinely perform liver biopsies in CF patients. It's invasive, it requires anesthesia. So something we really think about carefully in this patient population with already compromised lungs. However, it can be helpful to rule out other causes of liver disease. So something we do have at our disposal. Management of these patients, really, as I said, there's no effective therapy to prevent or treat CF fibrosis, but how do we support these patients and manage their complications? A big one in CF, for everyone in CF, is nutrition. So we really want to optimize nutrition and growth. Those with CF liver disease have further increased risk of fat malabsorption due to insufficient bile acid pools. So you may want to supplement these patients with medium chain triglycerides, because these MCTs are absorbed by passive diffusion directly via the portal circulation, and you don't require that formation of micelles or bile salts for absorption of these MCTs. You also want to think more closely about their fat-soluble vitamin levels, which we should be monitoring anyway in this CF population. And then just to know that chronic liver disease is a catabolic condition, so they have increased caloric requirements, and then increased rates of CF-related diabetes and metabolic bone disease. So recommendations for the foundation is that these patients with liver involvement should receive a nutritional assessment with someone experienced in CF every 6 months. And that those with advanced liver disease should actually be screened for CF-related diabetes, even if they present earlier than the traditional screening for CF-related diabetes, which should start at age 10. What else can we do for these patients? Because obviously it's frustrating when you have a patient with advanced liver disease and you don't have a lot to offer them. The main thing I talk about is, or what I talk about a lot, is reducing additional insults to the liver. So with my teenagers, I really talk about alcohol, avoiding, alcohol in general, or especially binge drinking, which can really tip a liver over the edge. And I've seen it happen, like a CF cirrhotic patient, well, not even full cirrhosis, was doing pretty well from a liver disease perspective. And then, a weekend of binge drinking and she was in liver failure, whether it was all that, or additional things, we don't know. But, alcohol, herbal remedies, prescription medications that could be hepatotoxic, vaccination against infectious hepatitis. And in those with portal hypertension, I counsel about avoiding NSAIDs due to increased risk of GI bleeding. So basically, the CF Foundation new guidelines just recommend consultation with a pharmacist every 6 months to really evaluate sort of polypharmacy, high-risk medications in those with CF liver involvement. I can't do a talk on CF liver disease without discussing ursodiol. It's a very controversial topic when thinking about CF liver disease. Historically, any CF patient who had some mild elevations in their liver enzymes, ursodiol was thrown on. It can make the labs look better, but honestly, it has not been found to impact clinically relevant outcomes in CF liver disease. So portal hypertension, need for transplant, nutritional status, and the most recent Cochrane review concluded that there really is insufficient evidence to support use of ursodiol in CF. So actually, a lot of my patients who I see for the first time who've been on ursodiol for years and they don't even know why they're on it, I'm trying to take them off slowly, just reduce their medication burden. So that's basically mirrored by what the CF Foundation says. They recommend against the use of ursodiol to prevent advanced liver disease. However, there really isn't any studies or data on those coming off it. So they're really saying up to your discretion in these patients for removing ursodiol. I'm going to quickly talk, we're getting short on time, but this is what scares gastroenterologists the most, are these esophageal and gastric variceal bleeds. Variceal bleeding rate is about 6%, 7% within 10 years of diagnosis of cirrhosis, and the mean age of the first bleed of 18 years. Primary prophylaxis is typically not recommended in general for pediatrics with varices. That means going in and doing something about the varices before there's been a bleed. But treatment includes band ligation, or in some cases, non-selective beta blockers. However, in the CF population, there has to be a discussion with the pulmonologist if you're thinking about using non-selective beta blockers. Refractory cases, you might need to do a shunting procedure, so bypass the diseased liver with the tips or other various shunts, but that comes with complications of shunt obstruction and hepatic encephalopathy. So basically, the CF Foundation says go based on other liver disease guidelines in terms of managing varices in CF. So for the adults, go based on the American Association for the Study of Liver Disease, or the Bobina group, but no specific recommendations for variceal surveillance in children with advanced liver disease. Hypersplenism from portal hypertension, you might want to counsel about avoiding contact sports, but I don't recommend splenectomy or even partial splenectomy. Ascites is really a poor prognostic indicator and should trigger evaluation for liver transplant. Encephalopathy is rare, but again, this can be something that can be suddenly occur in a patient with CF liver disease due to an acute insult. So an infection, excessive protein intake, GI bleeding. As I said, it can develop after a portosystemic shunt. And again, this should trigger you to consider evaluation for liver transplantation. The other thing is screening for hepatocellular carcinoma that we're not typically thinking about in kids, but those with pediatrics with cirrhosis or suspected cirrhosis should have annual hepatocellular carcinoma screening with an annual ultrasound and serum alpha-fetoprotein. And if it's an adult, you should just follow the current guidelines for HCC screening. Indications for transplant are cirrhosis with evidence of hepatic decompensation or synthetic dysfunction, so coagulopathy, elevated conjugated bilirubin, low albumin, nutritional issues. If you're having uncontrollable or recurrent variceal bleeding, hepatic encephalopathy, ascites, or poor growth and nutrition, secondary to liver disease, which is another one that's specific for the CF population. This is essentially saying the same thing, that if you have portal hypertension and non-compensated liver disease, it should really trigger you to be evaluating for a liver transplant. But in this setting of uncontrollable variceal bleed, you can consider a portosystemic shunt as a bridge to transplantation to try and manage the intractable variceal bleeding. Prognosis for these patients, these are just UNOS data for liver transplant, liver lung, liver pancreas. But one thing I would just like to point out is that children and adults with CF had lower post-transplant survival rates compared to non-CF patients. And that has been shown a clear benefit of early referral to a center with experience in CF-specific related transplantation. I have 2 minutes. I'm just going to touch on the modulators. These CFTR modulator medications have changed the face of CF in terms of respiratory health. And these patients are life-changing in terms of how long they're living and how healthy they're living. And they are just amazing drugs. So they target different areas of where the CFTR protein production is disrupted. So they are divided into potentiators and correctors. So the potentiators are for those people who have functional CFTR that reaches the cell surface, but the channel isn't working properly. So potentiators increase the function of CFTR channels on the cell surface. Correctors really improve the processing and delivery of a functional CFTR protein to the cell surface and increase the amount of the CFTR on the cell surface. So they target different areas. overall, we don't know how CFTR modulators are going to affect the liver long term. And this is an area of an active investigation for me and various other GI and hepatologists across the world. So really, we can't really say much from the guidelines perspective in terms of these modulators, but we do think that the benefits to CF lung disease outweigh any liver-related risk from these modulators. However, these modulators are metabolized through the liver, so it's important to monitor LFTs at baseline and every 3 months, with more frequent monitoring in those with a history of elevated liver enzymes or hepatobiliary disease. In those who do develop increases in their liver enzymes, you may have to discontinue temporarily or permanently, or even reduce the dose of these modulators. And there have been sort of rare cases of serious adverse liver events that have been reported in the setting of drug-induced liver injury. I was going to talk about my specific research, but I would rather a little time for questions. But basically, I'm studying one of the newest modulators, Elastography, Tezacaftor, Ivacaftor, to see how it's going to affect the gut microbiome in those advanced liver disease and those without, and to monitor changes in the gut microbiome and markers of liver fibrosis once the patient is on this modulator. So to summarize, I know this was a lot of information, but the main points is that some degree of liver involvement in CF is common, and the pathogenesis of liver disease is likely multifactorial. What I really want to emphasize is the goal here is really to identify patients with CF liver involvement, especially those who are at risk of progressive liver disease. And that's where these guidelines came from. We really just need better screening and more consistent screening. And, you know, cirrhosis and portal hypertension is the thing that we worry about most. It is rare, but it's serious complication and associated with poor survival. And hepatic decompensation, again, should trigger evaluation for liver transplant. But in terms of the modulator therapies, we don't know yet. So with that, I would like to say thank you. That's my email. Happy to answer any questions today or at a different time.
Thank you so much. That was fantastic. I can see one question in the chat so far in the Q&A. So Dr. Ashish Patel from GI says, thanks for the great presentation. 2 imaging questions. One, any experience with liver multiscan with CF liver disease and CF? And do you think point of care ultrasound might be beneficial for both early diagnosis as well as patient and family education of liver disease impact?
Yeah, so I think we haven't done a lot of experience with liver multiscan in CF specifically, but I think there's going to be a lot more, you know, decisions about imaging this patient population. In terms of the point of care ultrasound, I do think that would be a great thing to consider. I think, you know, this is going to be, these new recommendations are a significant increased burden for the CF population to be having to do this for all of them every 2 years. So, you know, if we can incorporate something in clinic, you know, and involve the families and patients, I think that would be great. That, you know, their clinic days are already so long as well. So, you know, trying to manage their quality of visit and time is going to be complicated with these new screenings. FibroScan can definitely be done in clinic. We use it a lot now for the research in the research setting, but I think that's going to be a tool that's many centers are going to get a FibroScan if they don't have one already, and it doesn't require a radiologist. It's, you know, pretty quick training to familiarize yourself with a FibroScan, and that can be quick and done in clinic, which would be great.
Awesome,
Okay.
thank you.
There's one other question that came in from a nephrologist that I can actually, she wants to have an ongoing discussion, so I can actually email that one to you, Nicole.
Okay.
But I wanted to thank you so much for this grand rounds. We're at time, so and I understand some of it. We had really good attendance today, especially from the pulmonary and GI divisions, and you'll get to interact with them later on at the noon case presentation. But I wanted to thank you and for starting off with such a great review of cystic fibrosis for all of our residents and everybody else who's not a subspecialist yet. Thank you so much, and look forward to the rest of the day.
Yeah.